Good morning, wherever you are. Good evening. My name is Tom Goddard. I'm the founder and chief executive officer of Integral Healthcare Solutions. And joining us in this month's webinar is Dr. Shawn Griffin, the CEO or the president of URAC, our favorite accreditation body. Dr. Griffin, thanks so much for joining me this morning or this afternoon.
Great to be on here, Tom, and I'm the president and CEO. I don't know what the differences are. It gets me tables here in DC when I use both titles. So
it's like at the Palm, I hope. So
they won't let me in there, but the Five Guys down the street is very popular. So.
Excellent, excellent. Well, today we're going to talk about telehealth. This is the headline event. We kind of warmed us up on this topic last month when we talked really more about the history of telehealth and telehealth accreditation. But we've asked you to join me today to talk about the latest, particularly in telehealth accreditation, because URAC is the not only the accreditation body of choice, but is the accreditor of telehealth programs of all flavors. So we are delighted to have you here. I'm going to flip over to our slideshow.
Yeah, just going to walk through some slides and talk about this, and then we'll talk some more and field some questions and those sort of things. So
yeah, and one thing by way of introduction to us, our format, if you haven't joined us before on these telehealths, is that you'll see as a participant, you'll see at the bottom of your page a place for you to ask questions, and we encourage you to ask questions, and we'll try to weave them in throughout. So if you have a question of Dr. Griffin, you can ask it, and I'll relay it to him. And then toward the end, we'll ask you to take some poll questions that will help us improve the quality of our webinars going forward. So anyway, a little about you. Tell us, who are you? You're about a year and a half in now, aren't you?
I am a year and a half in, and we actually, one of my slides has a little bit of background when we get to that. But my background is I actually grew up in a small town in Iowa. I went to school, University of Iowa for medical school, trained in rural family medicine. So my whole life was going to be in a little town in Iowa. I call them county seat towns. And the expectation was that I'd be on the sidelines Friday night with my friends covering the football game and stitching up people on the kitchen table and getting paid with chickens if need be. But my career has taken a bit of a divergent path. So I'm the first physician to lead URAC as a CEO. Prior to this, starting at the bottom, I was a full-time family medicine doctor, and then I became a chief medical information officer, first at Heartland Regional Medical Center, and then at Baylor College of Medicine in Houston, Texas. I became a chief quality and informatics officer, which is like being a CMIO for Memorial Hermann Physician Network, and built an ACO and a clinically integrated network and ran it for a few years with a team there, a bunch of great people. We were very successful, had about 500,000 contracted lives, and we were the most financially successful ACO in the country under the MSSP program. Then I went to do consulting for a couple of years because I was a bit of an expert, and so I was the vice president for clinical performance improvement and applied analytics at Premier in Charlotte, and traveled around the whole country sharing my experiences, and then decided that I would rather settle down someplace, and came to URAC as the CEO about 18 months ago. I've spoken all over the country. I'm considered one of the experts on population health and analytics and building networks and those sort of things. And at one point, class named me a population health all-star, and I helped them to design their IT framework for population health, and that got me into the idea of accreditation and standards and those sort of things. So been here now for 18 months, and we are the #1 telemedicine accreditor in the United States, and even starting to work with places all over the world on telemedicine and what makes a good telemedicine program as opposed to just some people stringing together some iPads.
Right, exactly. I'm so honored to have you join us here. Let's see if I can do this. Why is this not working? There we go.
So a little bit about URAC. We were founded in 1990. I always say that we have 30 years of sitting in that location, of being an independent third-party accreditor. We started out with utilization review. We do a lot of work in pharmacy, and Tom, you've worked with us a lot in pharmacy and those areas. But we also do telemedicine, mental health parity, remote patient monitoring. I'm going to talk about today, and the idea being is that the for me, when I think about accreditation, I think about that very often regulation sort of sets the bar for safety, but that accreditation really sets the bar for quality. And so just because you can do something doesn't mean you should do something. I was licensed as a physician, and that meant that technically I could practice medicine, but if you needed heart surgery, I was not the one who should be doing it because that wasn't my training. And accreditation is really sort of that above and beyond sort of demonstration of quality. And so that's what URAC has been doing, and we're going to keep doing it. One of the things that I claim all the time is that we're not for profit, we're independent. And as part of URAC, we don't actually sell consulting. So we think that by being an accreditor who doesn't sell consulting, it lets the consultants do the consulting work, and we're going to give you the test to work with you to see how good you're doing and to make sure that consumers can trust you.
You know, Doctor, a little story about my own history. But back in the day when I was the chief operating officer and the general counsel at URAC, my father, who was still alive then, asked me, when I explained to him what URAC was, he asked me, well, what gives URAC the right to set these standards? And I said, well, the board. I mean, the board is comprised of this incredible diversity, from the doctors to the hospitals on the one hand, and nurses on the one hand, and other providers, case managers, to we have consumers on the board. We have a regulator representing the regulatory world. We have labor union. And once he understood the diversity of the board, and he says, "You get all those people to agree on these?" I said, "Yep, that's it."
Yeah.
These are consensus decisions. They're not, nobody's beating anybody over the head to agree on these standards.
And I think, being here in Washington, D.C. and seeing how, people can work together or not work together, we do a remarkable job of bringing together those experts from all the areas and functioning a little bit as the neutral third party. I mean, we'll bring in the experts, and we just got through updating our telemedicine standards, and we brought in payers, we brought in providers, we brought in lawyers, everybody to sort of look at it and come together and make the best that they could. And then whatever we put together, we then put out for public comment. We say, here are the proposed standards, let's get feedback. And we have a very broad and open public comment program, so that what is finally approved by our board, which has all the constituencies that you talk about, is really meant to be sort of setting the bar and raising the standard for what is a good program and what makes quality. But yeah, we get some people who compete 6 days a week to get together on the seventh day and break bread and come up with standards together.
I thought they were supposed to sleep on the seventh day, Dr. Griffin.
Okay, then they'll fight for 5 days.
All right, there we go.
So one of the things that I like to do is literally, I'm sitting here in Washington, D.C. in our offices. We're about 8 blocks northeast of the White House. And it's important to sort of look back how we got to where we are these days. And in 2020, the political dynamics in January are very different than they are now. You in January, you had the Republican president in the Senate, you had the Democratic House. The Democrats had swept the 2018 midterm elections, and there were investigations and indictments, and you'd just come through impeachment. And the idea that you could get the government to work together on anything was, they probably couldn't agree to name a post office after somebody in January. There was just no idea that somehow things were going to be, anybody would be on the same side of any decision. And that's what we thought we were going to face in 2020, was just this sort of battle until the election, and then we'd see what we had coming out of the election. And if you think back, actually in January of this year, Donald Trump's chances of being reelected looked pretty darn good, because he was riding high on a big economy, and there was a loyal opposition, but the pollsters favored that Trump would probably have a cakewalk through to election, with stocks and everything at a high point. If you could do the next slide. So what I want to show you here is people talk about telemedicine, and telemedicine wasn't just invented in February. The actual first phone call back March 10th, 1876, Alexander Graham Bell, the first words spoken on a telephone were, "Mr. Watson, come here, I want to see you." What most people don't realize is that was actually a telemedicine visit. Alexander Graham Bell needed a Band-Aid, and so he was just asking the guy in the next room to come over with a Band-Aid, and that's the first telemedicine. Okay, that's not really true, but telemedicine, when I was in practice started in practice back in the 90s, I did telemedicine every day. It was a stack of phone notes that sat on my desk, and I would go through them, and there were some things that I needed to see in person. There were some things I could just phone in, and that was telemedicine. And telemedicine was going on back in the 60s and the 70s at NASA. They would take care of astronauts when they were up on Skylab and those sort of things. So telemedicine wasn't just invented in 2020. If you could go to the next slide. But what it wasn't was popular. There was low utilization. If you take a look at the numbers, it was pretty much a niche thing, and it tended to be the technologically savvy. The federal government really wasn't embracing it that much. It was, there's the licensing requirements. You have to be licensed in the state where the patient is. Some states had rules that you had to know the patient before you could do a telemedicine visit. Then you had other states where, by golly, you could just connect and it was fine. But by the way, you wouldn't get paid for it. So a lot of doctors didn't do it, and the technology was clunky. And if you give doctors a clunky technology and they're afraid they're going to look stupid, they're not going to be big fans. And so it really wasn't doing that much. You didn't see it as part of most government programs. Most payers, didn't like to reimburse it. There were organizations that were advocating on its behalf. The American Telemedicine Association and some other organizations talked about it, but it didn't seem to be going anywhere. It was sort of this secret, like a band that your friends knew about, but nobody else did. And that's where they thought telemedicine was going to be. Next slide. So COVID-19, the coronavirus, comes storming into America, and all of a sudden, if you look at the picture that we have there, we've got some dollar bills. And the economy shut down, and the federal government decided that they were going to start shoveling money out the door. And telemedicine, they were going to lift all the barriers because people were afraid to go into hospitals and afraid to go into clinics. And so now telemedicine was allowed. And I like to say that back before COVID hit, every doctor was afraid that if they did a telemedicine visit that they would look stupid and that they were probably violating HIPAA, and they were going to end up in an orange jumpsuit because they'd broken some law they didn't even know about. And the federal government said, oh, all those regulations, never mind. We're going to assume that you're just trying to care for people if you're doing telemedicine. And even phone calls, we're going to reimburse you for a phone call. We're going to reimburse you for if you can talk to somebody on FaceTime. It doesn't even have to be a secure platform. If you go to the government website, they'll talk about how, any good platform is good enough now. And so all of a sudden, nobody was being seen in clinic. They were all seeing telemedicine visits, and it was just this tremendous ramp up. And hospitals went from this situation where they were doing all their elective surgeries and they were doing fine financially to where nobody was coming in and their finances were terrible. So the federal government started pushing money out the door. And it was these remarkable bipartisan, 96-0 votes in the Senate and 240 to 60 in the House and those sort of things. So people who couldn't play nice together all of a sudden were coming together because the country depended on it.
Dr. Griffin,
Oh, yeah.
I attended a URAC conference on telehealth 2 or 3 years ago, and I was really impressed with the people in the room and with the presentations. But by the end of the session, I concluded that the dominant issue was not even so much barriers; it was complete lack of interest or recognition by the federal government. It's amazing how a global pandemic can focus attention of an institution or cluster of institutions that just seem to sleep at the wheel.
Yeah. I think when we talked about it, and I was at the last telemedicine conference which we held last year. We actually didn't schedule one this year, which is good because we would have been canceling it anyway. But when you looked at it, there were programs that did telemedicine. I was in Houston, and there was actually one for telestroke visits where somebody would come into an outlying emergency room and the neurologist would get on the camera at Maine Texas Medical Center, and they'd look at the symptoms and diagnose them that way remotely, and that was telemedicine. So you were seeing these little telemedicine programs where somebody was an enthusiast and they would do it and they would find a way to do it and those sort of things, but it wasn't widely adopted, or it was the techno yuppies who thought it was really cool to get on their iPad with their doctor and those sort of things. But the platforms were bad. The technology was hard to find. When I was a CMIO back in the early 2000s, I looked at telemedicine. It wasn't as in any parts of the electronic medical records. There were all of the licensing barriers, the prescribing barriers, those sort of things. And so it was just really hard. And with COVID-19, CMS, Medicare, Medicaid, we will pay for it. The payers were all concerned, if we do telemedicine, are we adding cost? Because they weren't seeing it as a substitution for an in-person visit. They were seeing it as an additional thing that the doctors were going to bill for. And so the payers were concerned about, is this going to save money or is this going to cost money? And when I was, I have 5 kids, but when my kids were little, and you're calling the doctor at 2 o'clock in the morning to talk about your child, it'd be really nice to get some care. And if the doctor could see the patient, that adds some information that may be important for the diagnosis. Sometimes if you just look at a kid, I mean, I hate to say this, when I had a clinic, there were times where somebody would bring in their child and I'd look at them and I'd go, okay, they have a fever, but they don't look sick. And just looking sick was one of the diagnostic points. And so being able to have all of a sudden a video conferencing tool in my pocket that I'm using for work, I should be able to use it to connect to the doctor, and it's convenient and there are times where it's appropriate. But, when the federal government dialed everything back, everybody jumped into the pool. They say it's like 10 years worth of natural telehealth growth in 3 months because everybody was forced to do it.
Right.
So looking to November, the impact of COVID-19, the election is completely different than it was going to be back in January. The way the federal government has responded, both financially and with leadership and with guidance and all of those sort of things, have changed the dynamic. There's talk about maybe the fourth COVID bill being passed. And the bills that have been passed are remarkable bills. I mean, they are trillion-dollar bills, $2 trillion worth of economic stimulus and all this sort of stuff. It's like the government could not shove money out the door fast enough to try and prop up the economy. And now you've got Wall Street, which went through a massive correction, which is now back up where it was before, but you're not feeling it on Main Street. But now you have all of these people who sort of have sampled telemedicine and who go, I kind of like it. You get sort of 61% of people who do telemedicine say, I'd like to do that again. That's really convenient. It's nice not to miss half a day to go into the doctor's office and sit in a waiting room where I might catch something else while I wait to see the doctor. And so as this plays out, everybody in DC says, we're going to put some more controls back onto telemedicine, but they can't agree how much and how hard they're going to do it. There's been an executive directive about the federal government looking for ways to expand telemedicine, and they're putting money into broadband because telemedicine, sometimes telemedicine needs to be delivered in a place where you don't even have cell service. So does it have to be video to count? Can it be a telephone visit? There's places where it's incredibly appropriate. If you look at some of the studies before COVID on behavioral health support, having a video visit with your psychiatrist, it can be incredibly helpful in checking your symptoms and seeing how your care is going. Maybe that needs to stick around. Maybe for a child who went 300 miles for a surgery and you're just doing a post-op wound check, to be able to just put an iPhone camera on the wound and take a look at it. Maybe that's appropriate. But maybe if you're going in for surgery and you need to have your belly examined, it's not the most appropriate place. So what can stick around and what needs to go away as we look at this? So the sustainability, the technology is there, the platforms are there. If you Google telehealth, you're going to get, 60 million responses in 0.2 seconds, as there's all of the stories about telehealth and all these providers about telehealth. The EMR vendors are putting it in because what we don't want is we don't want further fragmentation of care. How do you make sure that your telehealth visit tracks down the rest of your visits? And how do you judge telehealth quality? Is telehealth really about, did the patient like the experience? I think that's part of it. But if you're a provider and all you're doing is giving a patient whatever they want over a video visit, you're just a vending machine and you're not following evidence-based medicine, and that's not what we want. How do we handle video visits? How do we handle non-video visits? What platforms can be trusted? What platforms can't be trusted? And how do you know that the person on the other end of the line who's wearing a white coat and a stethoscope is really qualified to be delivering your care? And then the big question that everybody is sort of standing around waiting to see what happens is, what's going to happen with payment? The federal government is sort of stepping into that a little bit when you look at what they're saying for Medicare Advantage. Very often they trial stuff in Medicare Advantage and they're putting some things in Medicare Advantage for telemedicine. But what are the payers going to say? Are the payers going to say, we're not going to pay for it the same as we'd pay for an in-person visit. That's going to go away when people can go back into the clinic. But is it going to get paid at 80%, or is it going to be paid at 20%? And how are physicians going to follow that, and what are they going to offer to patients? If I'm in a risk-based contract where I need to see people at the lowest cost venue possible, then I'm going to have telemedicine. You have some startups like Oscar Health, which are offering sort of online visits with primary care physicians for very small amounts. You've got baldness treatments where you can get online with a doctor and they'll send in a prescription and those sort of things. So what's going to stick around? The federal government is going to have a lot of say in what's allowed when it comes to HIPAA, when it comes to security, but then the payers, including the federal government, are going to have a lot to say in what payments and how does that drive behaviors.
Dr. Griffin, you're in contact with payers all the time. Have any of the large payers started to indicate an increased willingness to expand their notion of support for telehealth?
They're pretty much at this point sticking to the payers are slow to move because it involves the money. And they're saying that as long as COVID is an issue, they will continue to support it. Now, what's happened is a couple different payers in a couple different states have said, well, we're going to stop paying at parity on June 30th. And then as it gets close to June 30th and people go, you can't stop, we're still afraid to go. And then they extend it. So there's sort of these rolling deadlines that get pushed along. But the payers have shown that they don't want this to be the new normal. They don't want to pay exactly the same for a video visit that they would for an in-person visit in most cases. But the consumers, and that's one of the reasons why one of the things that we're doing is we're engaging with the employers. The employers are saying, my employees really like this. If I could, there was a push years ago for on-site clinics. If I could have a little on-site kiosk where my employees could go over and get checked by a doctor appropriately and replace an on-site clinic, that'd be really convenient for me, and I wouldn't have people leaving for a half day to go for a doctor's appointment. And so we're talking to the employers about, what do you want this to be? And a lot of the employers who are self-insured, they're paying for it anyway. So what do they want it to be? We can't just leave it to the payers to see what they want it to be. And that's one of the things URAC does. URAC convenes those groups to say, all right, what are we going to try? And if I've got the payers saying, we'll pay it at 20%, and the provider saying, well, if you pay it at 20%, we're not going to do it, and the employer saying, well, we need you to do it, we can be that Switzerland where everybody comes together and has the peace talks.
Yeah, that makes sense. I would think that ultimately the employers are going to decide. They have the big club here. So I'm glad there's a mediation role for URAC in that.
Yeah, there is, and in November, whatever the election comes out as, we're going to have some changes. We're either going to have continued divided government. I would actually argue that we're always going to have divided government, because even if you have one party, most of the parties are divided within themselves as to what they believe.
That's right. The Republican, the Senate couldn't get, even the majority in the Senate couldn't get the most recent package voted on or approved by the majority. So
right,
yeah, you're right on that.
So whoever's in power is going to face division within their own ranks. They're going to face competition from across the aisle. We're going to have to see sort of what the economy is doing, how people are back on their feet or not back on their feet. But if you think back to a year ago, this may seem like 1,000 years ago, but a year ago, the main push that you heard in medicine was the high cost of drugs. It was high prescription costs and those sort of things. And now, it's like we're looking to pharma to save us with a vaccine and with treatments and drugs and those sort of things. And it's interesting to sort of see how the dynamics play out in this soap opera that is Washington, D.C. One of the things that we experience in D.C. is we have all of these commercials, because the special interests will buy commercial time on the local stations, knowing that the regulators and the legislators are going to be watching TV. So we have these ads about how pharma is going to save us all. And we have these other ads about, drugs cost too much. And we have all of these about, hospitals are fantastic and they're saving lives. And then nobody's talking about costs right now, because it's about saving lives and it's about something else. And so we're going to have to see sort of as reality comes back on board, what is this going to look like? Mm-hmm. So when we talk about accreditation, one of the things that I hear all the time is, why would I accredit? Why would I go through accreditation? What's the purpose of accreditation? Well, accreditation serves many different purposes. I say that at its simplest, accreditation is an independent verification of quality. And when you think about the regulators would like to know whether something is quality or not. One of the interesting points is that regulators are showing more interest in accreditation right now because they're looking at budget cuts. The states are looking at budget cuts, the federal government is looking at budget cuts, and there's a concern about, if I don't have the people to go verify the quality, is there another organization that I can look to verify the quality? And URAC has a history in our 30 years of multiple deemed government programs, so URAC is a name that they know. And so a URAC accreditation, the regulators view that favorably as being something that they can trust and that they know that we're independent and we're not just, Steve's house of video conferencing saying that Steve does a good job. It's somebody independent, it's national leaders coming together. The payers, the payers recognize that they had a seat at the table, that when it came to what is accreditation and what is quality, that they can look at that and they can tell, and they think that that plays a role. For a long time, payers have been using our specialty pharmacy accreditation as a criteria for getting into their networks and for being allowed to dispense certain medications. Risk management. If I'm an employer and I'm going to offer a telemedicine benefit, is it an accredited telemedicine visit, or am I just throwing my money after somebody who's just in it for the money? Marketing. Some people use accreditation as a market differentiator. I used to joke, I say, if you look for top 100 hospitals in the United States, there's actually 3,000 of them that will claim to be a top 100 hospital in something. And it's because you can be the top 100 hospital in flooring, and something that has nothing to do with medicine, but you're going to have a top 100. It's going to be on your dashboard or on your website. Some people want to say they are accredited, that they have done the extra work, and hope that consumers will use that to differentiate in the marketplace. If I can get on my video camera and connect just as easily with my local hospital as I can with the prestigious academic medical center 3 states away, what's going to make me go to this one versus that one? And accreditation can be part of that marketing. When you say that you have gone to, the #1 accreditor, and we have received their accreditation, so what we offer is just as good as they offer. And part of that is when you look at who we accredit as an organization, it's a pretty good list of the top performers in telemedicine that we accredit. Go ahead with the next slide. So, like I said, we lead digital health accreditation. I actually don't like this picture, just to tell you, because I think it looks like a really tiny phone. I'm not sure whether they have the iPhone 2 is what they're holding here, but
Yeah.
I think that looks like somebody is playing in a dollhouse. But the idea of being able to get on your phone and talk to a physician, and ideally a physician that knows you. As a primary care physician, I'm a huge fan of continuity of care. And when you connect to telemedicine, if that visit exists as its own little fragment, we have just broken up more of healthcare. If you get a prescription if you connect to a doctor and they don't even know what medicines you're on or what you're allergic to or any health conditions that you have, that there's chances for mistakes. And one of the things that we talk about is, what's the continuity of care? What are your evidence-based guidelines that you're following? Those sort of things. And when other organizations offer telemedicine accreditation or telemedicine standards. When you look at their standards and they're on their first version and we're on our 4th version because we've been doing this for a long time, telemedicine just didn't pop up as a surprise to us. I mean, you mentioned, Tom, that you'd been to our conferences. We had been waiting for something to sort of change in telemedicine because we knew that this was a great opportunity for care to be delivered differently, more convenient for the patient, probably at a lower cost in areas where you couldn't get the care. I grew up in rural Iowa. You're not going to find a heart surgeon in Fayette County, Iowa. There's just not one there. But if you can go to your local doctor and maybe connect remotely to somebody down the road who's a heart surgeon, you're providing care in parts of the country where it wouldn't otherwise be available.
Doctor, I have an alternative theory about this photograph. It may just be that it's a regular size phone, but a giant is holding
a giant person. Yeah.
Yeah, a massive human.
Massive human. So this slide here, when it comes to our telehealth accreditation, one of the things that we did is we looked at what was out there, and we said, there's more than one variety of telemedicine. And I'll talk really briefly about this. There's the consumer to provider. This is it's late night. I'm gonna get on my phone and connect to a provider. This is patient initiated. This is that sort of care. when you go to the provider to consumer, think about that as like follow-up. Imagine that your psychiatrist wants to check in on you and see how your symptoms are doing, those sort of things. But then there's provider to provider. This is that, a specialist who I connect to at my local doctor's office, and he comes in and I'm working with the physician who's local, but I've got a physician who's remote, bringing the best of the world into your local community. And those are all different. And when you think about what we've put together, we have service types, consultations, we have specialty care, but we also have, what kind of apps are you working with? Where is it being done? It's very different to talk about, I need a medication for my baldness. I need to get a refill on my baldness medication versus I'm a prisoner in a correctional facility and I need to connect to a physician who can't come into my facility or something like that. And telemedicine covers all of those areas. There's the video visits, there's the phone visits, there's even just, you're in an ambulance and you're on your way to the hospital. Can they send an EKG from the ambulance into the cardiologist who's going to be waiting for you to decide if you need to go to the cath lab or if you just need to go be observed for a couple hours?
I must say, Dr. Griffin, all these references to baldness medication, the suffering is real.
It's probably something Freudian as I'm looking at, as I'm talking to you. I could have said, would you have rather I picked a different disease? That could have been even more awkward.
I think so. I think even calling it a disease is
a condition.
There we go.
Treatment of a condition.
By condition is exactly.
From now on,
we could call it a feature.
All my references will be to my own personal obesity. I'll just go with that, and that way you won't be uncomfortable.
I appreciate it.
So, some of our telehealth clients, I think this is just an outstanding list of organizations that have come to us and said that, not only are they accredited by us, but they contribute to our standards. And there's names on there that we recognize. There's academic medical centers, there's direct to consumer, there's actually texting organizations that are focused on behavioral health. There's specialists and consultations. So I think that this is a great example of how when you think of who's been through our door and who we have served, that's a pretty good all-star list there.
And also the diversity. There's some of the largest players in the world, and some that our viewers might not have ever heard of. So that's one of the things I've always liked about URAC. When people have asked us over our 20 years in business, well, who are your clients? I say, well, just think of the largest healthcare organizations in the country, and then imagine the smallest that you can imagine. And that's who URAC serves. And that's wherever URAC goes is where we go. And so you can see that reflected even in this world of telehealth.
Yeah, and actually one of the things, there's nothing in the slides about this, but one of the things that we're looking at is with everything that's been going on in the country, we're going to be doing some things around health equity and access as sort of an initiative for our company. And one of the things that we're looking at doing is some of the federally qualified health centers and some of the smaller providers who would have challenges with getting into these services and understanding what best practices are. We're going to be working with some of them to help to extend this service so that it's not just done, so that everybody receives the care that they need to get no matter what the venue. So look to us to expand this more into some of the FQHCs and in some of the underserved areas, both urban and rural, as an attempt to broaden our expertise in helping the organizations do this for people.
While we're on this topic, Dr. Griffin, I do want to invite you to talk a bit about accreditation generally. It's entirely conceivable to me that some of our viewers are not all that familiar with the URAC arena. And one of the things that's always, since I first came to URAC about 23 years or 22 years ago, what struck me was the scalability of accreditation standards at URAC, that you don't really have to be, United Health Services. You can be one of our clients with 1.5 FTEs, and there's an IRO, and they're still accredited. And the scalability of accreditation, particularly at URAC, is I think something worth spending a minute or two on.
Sure. So I think later on we have some slides about the process, but one of the things that accreditation is intended to be is it's intended to be a learning experience for the organizations that go through it. And when we deal with organizations, some are new accreditations, new to the business, and when they sit down with URAC standards, it may be, oh, I hadn't thought about that part of it.
Mhm.
There's all the different parts that make up an accreditation, things like credentialing, how you handle surge capacity. Just as an example here related to telemedicine, I was speaking with one of our accredited telemedicine organizations, and I asked them, I said, so how has COVID affected your business? And they said, we were going along fine. We had a model, this sort of stuff. And when all of this sudden demand hit, they said it was the strangest thing. We went back to our URAC accreditation program and some of the answers that we turned in and some of the things that you had asked us about how would you credential providers in a hurry when there's this surge of demand. They said we pulled out our answers to the URAC questions and the things that we learned, and they helped us to scale up during this disaster. And URAC is meant to ask the questions to prepare you for the next level. And it's not meant to be punitive. It's sort of like, this is how some other people have been successful. These are the things that you need to do. But also there's some flexibility in it. It is very rare for URAC to say anything really particular. We say you need to have evidence-based medicine approved by clinical leaders. We don't say you need to have a committee of 27 clinical leaders
Right.
representing all the specialties. We say, what is your process for doing that? And when we do an accreditation review, we say, show us how you meet this standard. It's not, this is exactly what you have to do. Now, we also sometimes have people say, well, can you tell us how you do that? And we're happy to share those experiences from other organizations, but we don't mean it to be, you have to be exactly this way. I mean, when you look at somebody like Teledoc and a huge organization now with an over $1 billion valuation, and then you look at somebody like a smaller integrated healthcare system, they're going to meet a URAC standard in different ways, and we're going to be approving of both of them as long as they're meeting the standard. And I think
Or,
that flexibility is incredibly important, and the education process to help people through it. It's not that we don't tell you what we're going to be looking at. We share with you the standards. We talk to you about it. We have reviewers who will talk to you about it. What's your policy for such and such? Oh, I don't have one. Okay, let's get one put together so that you can meet this.
Yeah, we've noticed this over the years as a new field in healthcare emerges, as happened a decade ago, for example, with specialty pharmacy. We have a lot of new entrants into that world, and then they find out, oh, we need to be accredited in order to get paid, and then they come to URAC and they say, well, what's that involved? And then they realize, oh, we weren't ready to actually do that yet.
Yeah.
But now we can see a road path into that arena. So it's not just about getting your ticket stamped so you can get paid. It's about actually learning how to do it properly.
Yeah, and in my own personal experience, one of the things that we do is we put our standards at a glance out on the web. And we
Right.
do that because an organization should be able to look at the standards and go, oh, I thought about these 3 things, but I missed these 2, that sort of stuff. And the other thing I don't want, is there is a tendency sometimes for accreditation to be, we're going to do the next 3 months worth of work and get everything just absolutely perfect, and then we're going to take the test on one day, and we're going to then wait till all the surveyors leave, and then we're going to put everything back the way that it was and go back to our normal function. It's really meant that you're ready for accreditation any day. And one of the things that we have is if we have an organization that's been through our accreditation process and someone has a concern about what they're doing, they can call in and they can basically have a grievance and say, this organization isn't doing this, which is one of the standards, and we'll do an investigation. And I think that that's important. And it's not meant as any sort of, how we got you. It's not a speed trap along the highway or anything like that. It's that accreditation is not meant to be, I was healthy on June 1st, but the rest of the year I was junk.
Right.
So one of the things, the left side of this slide is about telemedicine and the role that telemedicine plays, but on the right side is remote patient monitoring. One of the things that we're seeing is that as people talk about telemedicine and the capabilities that are within that, there's also remote patient monitoring, which comes very quickly. A few months ago, I got my first Apple Watch. I had been delaying on getting it, and now that I have an Apple Watch, I'm working on closing my rings and I'm checking my pulse and all this sort of stuff. But the idea is that more and more devices are going to be able to monitor our health. And sometimes it's going to be very focused. Maybe it's going to be a blood pressure cuff for somebody who has high blood pressure, and it will transmit the results to the doctor's office, or it's going to be a scale for somebody who has congestive heart failure, and they're watching their weight and their salt intake or those sort of things. But when you start doing telemedicine, you start going, what remote patient monitoring is like 80% of telemedicine, and then some other things thrown on. And so remote patient monitoring is an area of accreditation that we are seeing expand. You know, telemedicine is really hot right now because of COVID and people not wanting to go to clinics and those sort of things. But we think remote patient monitoring is going to be following quickly behind that. That's going to be somewhat dependent upon payment. When I was at Memorial Hermann, we actually did some remote patient monitoring for patients, and it was part of a pilot program with a payer where they paid us a certain amount to do it, and it was successful. But then when the pilot was done, nobody would pay for it anymore, and so we had to sort of fall back to our old way of doing things. If you go to the next slide. So, you know, it's for provision of patient care outside of traditional venues. If you go into the emergency room and they don't want to have people come into the hospital, you know, go home, and here's some devices that we can use to keep an eye on you. Maybe you've had surgery and we need to keep an eye on you a couple days, but you don't really need to be in a hospital bed. Maybe you need to be moving people out of the hospital for beds for more serious diseases. We expect it to be a lower cost of care. I often say that if not for the doctors, the hospital is very simply a very expensive hotel with bad food. You know, what can you do at home where you're more comfortable? And also earlier detection of health deterioration. Let's say that you have an elderly relative who has some health conditions. You know, can you be checking in on them? Can you see how they're doing? Those sort of things with devices where they don't need to be fully in assisted living or a nursing home or rehab or anything like that. Is there a middle ground there as people want to spend more of their life in their own home, in their own setting? So the remote patient monitoring, we're talking about portable or wearable devices. It has to be secure transmission of data. You know, just because you have a cool platform doesn't mean you should be practicing bad medicine. We don't want to have privacy leaks. We don't want to have, you know, HIPAA violations, those sort of things. We do say that the remote patient monitoring must involve a provider. And by that, if you look at URAC standards, we often talk about clinicians leading the oversight of clinical things. And some startup companies are coming in and they're like, oh, you know, we're just a couple people who thought it'd be really cool to put in blood pressure monitors at home, and we're going to watch the numbers. And it's like, okay, what's your medical background? Well, we don't have any, but we think it's a really cool tool. So, you know, we do make sure that you have
Yikes.
clinical oversight for the things that you do. And the FDA guidelines, the FDA is certifying, you know, more devices. You're getting a little otoscope so you can check the ears of your kiddo who might have an ear infection, or blood pressure cuffs, or stethoscopes, those sort of things. So we think that remote patient monitoring is complementary to what you see in telemedicine and telehealth. The focus areas, you know, this would be, if you look at our standards at a glance, you know, we have mandatory requirements, business requirements. You know, what's your business continuity plan? That was the thing that helped some of our telemedicine providers when COVID came about, was their business continuity plan. Professional oversight, clinical workflows. What is appropriate for remote patient monitoring? What is appropriate for telemedicine? What is not appropriate? Risk management, you know, what are you going to do at 2 o'clock in the morning if all of a sudden you get a dangerous blood pressure reading? You know, how are you going to address those things? Who are you going to call? How do you escalate those types of things? And the technology. It used to be that the technology was the barrier for doing things like telemedicine. Now the technology is there, and we've got our phones in our pockets with our cameras, and grandma's doing you know, a meeting with the grandchildren over her iPad. And how come she can't have a doctor's visit just as easy? Next slide. The accreditation process. I have been pushing to make the accreditation process faster and faster. I'm driving my people absolutely nuts because I want to get this to where we're under 6 months on average with what we do for accreditation. And the reason being is that you need some feedback, and you upload your application. We do desktop reviews. We do a validation review. We take a look at how you're doing things. Maybe we need to do an on-site depending upon what you're doing. It goes to a committee. We score your evaluation, and then you're done. So we're going to try and make this, we say that with the accreditation process for telemedicine, we're getting pretty consistent doing it under 6 months. For remote patient monitoring, we're expecting the same. Now, we're not there with specialty pharmacy and some of our other accreditations that take a little bit longer, but we're streamlining our desktop review process. We're needing fewer and fewer organizations are needing more than 2 desktop reviews, so we're trying to make that more sort of the standard function as we go through these things. And we really want to push people through because you've got care to be delivering, and nobody wants to be in the accreditation process for 6 years as they're waiting for a result.
That's for sure. That is for sure.
Well, I have run through my slides. Sorry, it took me a little bit longer than I was expecting, but happy to open it up to questions that have come in and thoughts that you have, Tom.
We haven't any questions that have come in. I'll let folks know. In fact, I'll let you know that we're just about to start sending out our poll questions. We would ask all our viewers to please, as we close up here, please please help us out by responding to these questions, and we'll definitely get back to you if we have answers to them, and we'll definitely modify how we do these in the future to help improve them to meet your needs. You have is it accurate to say you have a new version of the telehealth standards coming out?
It is accurate. You know, we just like things have changed here in Washington, D.C. If you look at telemedicine in January and what the models look like and how things were functioning, you know, the regulations have changed, if nothing else. And so what we did is just over the past month or so, we brought together industry experts from a lot of the organizations that you saw on the list, and also, you know, from the federal government and those sort of things to give their input. And so we're updating our standards. It's going to be our 4.0 standards. They are getting finalized now. You know, whenever you put something out in this day and age, you run the risk that Congress is going to pass something in the next 15 days that's going to mess you up. But we think that it's important with everybody coming into telemedicine at this time that we give an updated set of standards that's reflective of the situation on the ground. And so I think one of the further slides has the contact information for my organization. It has, you know, who you can call and who you can email to find out more information. But go to our website, urac.org, and you can take a look at I guess here's the connect with URAC slide, you know, our business development, but also, you know, just go to our website and look around, go into telemedicine and look at the standards. But we're going to have some new ones coming out. You know, the advantage is that if you go now and you sign a contract, then we accredit you under the old standards. But the new standards will be coming out. We're going to be talking about some quality measures that we're going to be adding to the programs because, you know, everybody's saying, how do I know that it's quality? And so we're adding some things in there so that you can do that. Not meant to be punishment that you're going to measure results, but we're also going to allow anybody who measures to benchmark themselves against others to sort of see how they're doing, because I think that that's the best way for us to have a high quality available service to everybody.
So please, viewers, take note of how to contact URAC, and you can pester them on if you're desirous of getting when is it going to come out? You know, how much time do I have before we have to comply with the new standards? So business development will be able to help you with that. They're very knowledgeable and helpful there. Here's a question that's come up. Are there any you know, in a lot of your accreditation programs, there's deeming by the states. Mm-hmm. Have you started to see any regulatory sniffing around about that in your world, where regulators would be grateful if you would step in and start accrediting?
The short answer is yes, and that's because as states are looking at this, as you have medical boards that oversee licensing and those sort of things, they're looking at what controls can be put on to make sure that this is being done well. And the regulators are looking at budget cuts, and so you've got all these departments of insurance and those sort of things who are concerned that they're going to have to make do with less people, and accreditation has very often served that purpose. So we have a multiple number of states that have talked to us, and even the federal government has said, explain to us your accreditation program, the things that you check, because we have more experience with accreditation and quality in telemedicine than a lot of the governments do, and so they're asking us, they're using our accreditation standards as a guidance for what's worthwhile and what's meaningful, and to be the number one accreditor who's done this the most means that we know the most on this one. So yes, states are doing that. They're asking those questions. They're still waiting to sort of see what the federal government does for dialing back on controls. And I think that I always watch Medicare Advantage as sort of a guidance for where the federal government is going, and the fact that they are allowing, telemedicine and telephone visits to contribute to Medicare Advantage risk scoring, to me is a sign of where they're going. And the executive guidance in asking, I think they asked like 50 payers to sign on to expanding telehealth going forward, is an example of this is going to become more and more common, and we'll work out the payment and those rules. But I wouldn't be surprised if accreditation and deeming status follows along with that.
I will flip to the Integral Healthcare Solutions contact page if I can. Oh no, I can't. Why is that? Oh, here we go. Nope.
Whoops,
there it is.
There you go.
And but we do have a couple of questions from viewers. In your explanation of how evaluators approach reviewing standards, they're let's see, hold on. They're dictated by what they actually dictate what the standard means and what evidence is needed, although I'm not sure that's completely accurate, because URAC decides what evidence is required to demonstrate compliance. But they do raise a good point here. How are you ensuring that the reviewers are educated and consistent in their approach? And I know you have a robust mechanism to ensure that, and it would be great to hear you talk about that.
So I'm going to highlight two things. First of all, actually I got three things. So whenever we roll out new standards, we have mandatory education for all of our reviewers to sort of go through and give them the updates and to speak with them about what should constitute satisfying the standards versus not satisfying the standards. Another thing that's a bit unique about us is we employ our own reviewers. So it's not that we're contracting with somebody and we have, 600 people around the country who do this, one day a year. And so there's no consistency there. So we employ our own reviewers. We think that that's worth it. And then the other thing that we do is we actually have developed an app for tracking inter-rater reliability. One of the things, if you look at statistics and analytics, is the idea of, Tom says this is red, Shawn says this is red. Is it really red? And so we actually will take score sheets and reviews that are done by reviewers, and we'll have other reviewers review them to make sure that they agree with things, and that helps to sort of stitch our teams together for the consistency. The other thing is let's say that, it's less likely because we employ our reviewers. We educate our reviewers, we compare our reviewers to make sure that their results match. But let's say that something comes up and you had a reviewer who honestly just had a really bad day, he was grumpy, that sort of stuff. We take a look at those results. Anybody who goes through the review process and who misses, mandatories or who falls short, there's an appeals process that we can go through where we actually will take it to an independent group to review and say, the reviewer said that they missed this, but here's the information that they supplied to say that they met it, and then we have other people review it. So there's about 5 or 6 different layers and checks and balances on the process. And also, we don't want to do that. We want to be consistent because we're putting our name on this as well as your name on it, that you're doing well.
And I'll just vouch for that. We have sometimes folks don't come to us early enough, and they go through the process and they get a denial, and every once in a while they ask us, those folks who didn't come to us for the accreditation process come to us for an appeal. And we've assisted a handful of applicants on appeal, and I will attest that it's not a rubber stamp process at all for the reviewer's decision. There is a freedom to act other than the way the reviewers saw it that we've seen in that process. So which is uncommon, actually. My experience in the world of appeals, it's uncommon for any appellate mechanism in the private or public sector to actually overturn.
Tom, along those lines, one thing I want to mention also is all of our review decisions and our appeals are done blinded. So if I've had people who say, well, they're not going to approve us because, we're their competitor, because somebody on your board is our competitor. And it's like, we don't see that. We actually blind the applications. Whoops, my light just went out. We actually blind the applications so that that's not intended to be an issue. And we haven't found it to be an issue. It's one of those things where as much as we can, we'll hide who it is, where it is, those sort of things, and just bring it, oh, no, there's going to be no light. Just to make it as fair as possible. Got
it. We have one other question from a viewer. Have you detected any patterns within the standards, the programs that are out there now, of like what areas cause the most trouble, what areas, or if you have detailed standards within those areas, cause the most difficulty for applicants and compared to the others?
Well, I think that there's sort of this curve where organizations, when they first come into it, they don't know what they don't know. And so we see people who maybe haven't tightened up on credentialing and those sort of things. That can be a weak spot for them. Also, their evidence-based guidelines and their clinical oversight can sometimes be a challenge. And so those are some areas that people tend to need to work on. It's very often not the technology, because very rarely is it homegrown technology. Very often they will have sort of a third-party vendor who brings the technology to the table.
Mm-hmm.
It's more sort of making sure that they have the escalation processes, the triage processes, make sure all their credentialing is tied up. And some of it's just documentation. I mean,
Sure.
you may have a verbal policy for how you handle something, but do you have a written policy so that you have consistency within your organization?
Yeah, but you could have just described the most troublesome standards for most of the URAC programs. I mean, credentialing, decisions about criteria, review criteria, and then documentation, and documentation. Exactly, as we said, for all of our experience with URAC, if you haven't documented what you've done, then you haven't done it. So, and
Yep.
that's a lesson for a lot of our clients. So I don't see any other questions. Any closing remarks you'd like to make, Dr. Griffin?
I'll just circle back to something. I think that telemedicine is currently going through a boom time, and it's going to dial back to something a little more reasonable. There's going to be some controls to get put on it. I think that recognizing that you may be 80% there, but that last 20% is probably stuff you don't know. And so looking at our standards, even if you're not going to go through accreditation, take a look at our standards. Think about how you would address them. I think that accreditation, as more and more organizations have jumped into this field, I think accreditation is going to help to be a way to distinguish yourself in the marketplace. I think you're setting yourself up for a good relationship with the regulators as they come into this. And we throughout this whole thing, one of the things that we've done at URAC is we've said, what can we be doing to help people deliver better care? In some cases, that meant that we pulled our reviewers off the road because we didn't want to interfere with care in areas where they're really getting slammed. And in other places, it's okay, we need to do an update on our standards because telemedicine is being delivered in so many different ways by so many different people that are not doing it right. By updating our standards, we can help them to do better. So, if there's ever anything along these lines, reach out to us. You can reach out to me. You can reach out to our team. I thank you guys for taking time out of your day for doing this, and Tom for inviting me, and your viewers for paying attention. I think that this is a growing area, and I think remote patient monitoring will be coming behind it as sort of the next thing as we look for ways that people don't have to go into areas and risk illness in the near future.
Absolutely. And Dr. Griffin, thank you so much for joining me this morning. I know our viewers appreciate your taking your time to share what you know, which is a lot about telehealth and telemedicine. And I'll just remind our viewers that Integral Healthcare Solutions is a nearly two decade old accreditation consulting firm that specializes in URAC. And wherever URAC goes, we go. And so if there's anything that we can help you with in terms of preparation, please see the contact information on this last slide, and write me an email directly. This doesn't go to some offshore call center. Just that phone number and that email go straight to me. So give me a call or shoot me an email, and I'll be glad to talk to you about your questions and see if we can be of some assistance. And I won't charge you a nickel if you do. So at least for that call. So anyway, Doctor, thank you so much for joining us, and see you when the next at the next opportunity. And this has been a great pleasure for me.
Always good to talk to you, Tom, and thank you for all the help that you give to our clients.
All right, take care.
Okay.
Bye-bye.